No, I was just asking, before we get started, if there's any questions, comments, concerns. Is everybody good?
You're not giving us the answer.
I'm not giving you the answers. You have all of the knowledge you need to pass your exam. You're gonna do great.
But do I?
You do. You do. You do. Just remember that a lot of what we do is application and analysis, right? So it's not just knowledge comprehension. You have to take what you know and then apply and analyze to a lot of it. Okay? So on that exam breakdown that I gave you, across the top where it said like the number of questions and like the question type, the MC was multiple choice, and then like the AA was like application or analysis, or KC was knowledge or comprehension. So your knowledge comprehension is just kind of regurgitating information, right? But your application and analysis is taking all of it, looking at the big picture and analyzing what's going on and what you have to do for your patient. Okay? Cool? You're gonna do great. Promise, you're gonna do great. Okay? All right. So we're gonna get through lecture. At the end of lecture, we're gonna do an activity. In your groups, you're gonna pick one of the disease processes or disorders that we talked about. You're gonna concept map it out, and you're gonna do that NCLEX style questions assignment that's in Canvas, that in-class activity, okay? So 3 groups can do it on the whiteboard, and then I've got the post-it note that you can do it on there, okay? When we get to that, I'll give you a little bit further instruction, but essentially, you are all going to create 5 NCLEX style questions within your group. You're gonna post them in that discussion along with your concept map. And then I will pull 10 of those questions, word for word, just how you have it, and it's gonna be on your next exam. Okay? So the 50 questions on the next one, 10 of them will be ones that you guys created, so you'll have the question and you'll have the answers as well. Okay? So, I won't give you the answers for this one, but you'll have the answers for the next one, at least 10 questions.
At least 6, 7.
Yeah, about 6, 7. Right? Okay, so we're gonna touch on a couple of different chapters. So there's some things coming from like neuromuscular, there's some on mobility, sensory, endocrine. So 4 chapters kind of all together combined in this lecture. Okay. As far as the neuro stuff, some of it is review. So we'll talk about like intracranial regulations, we'll talk about like hydrocephalus, meningitis, things that cause ICP. We'll talk about ICP kind of review because you guys talked about that in critical care, right? Yeah. Okay. So then we're just going to apply those things to pediatric disorders that you'll see, okay? So let's talk about some differences in anatomy and physiology of the neurologic system. So when does your neurologic system really start to develop? In utero, what time?
Right away.
Okay, it's one of the first things, right? So during the first 3 to 4 weeks of gestation, during this stage, it's really crucial that they're not exposed to any sort of toxins or like teratogens, so those things that cause birth defects, right? And what?
It was just funny because most of them don't even know they're pregnant.
Exactly, right? This is why it's a problem, because the neural tube starts to develop so early on. When do most women actually find out that they're pregnant? Somewhere between like 5 and 8 weeks, right? On average, when the neural tubes have already started to develop. And if they haven't, they've been smoking or they've been taking certain medications or they had a maternal infection during that time, all of those things could lead to neural tube defects. If they weren't taking enough folic acid, right? Folic acid leads to what defects specifically?
Spina bifida.
Like spina bifida, absolutely. Okay. Then we see that at birth, they have a unique set of neurologic vulnerabilities. Their skull isn't fused; it's pliable, So if the birth canal is too small and their head is too big, that can squish them, right, and cause some issues there. If they've got a nuchal cord, that can cut off oxygen supply to their brain, right, leading to what disorders? Cerebral palsy, absolutely, right? Okay. And then in childhood, we're seeing that their spinal cord is more mobile than in adults, making them very susceptible to injury. So they've gone diving, they've hit something, they've had some sort of bike accident. They've got shaken baby, right? Something that we'll talk about. Okay, all puts them at unique differences for neurologic issues. Let's talk about proportions of the head. Is the size of a child's head much larger in proportion than it is to an adult?
Yes.
Yes.
Wow.
Which makes them very top heavy, right? So they, have a tendency to fall over more, they're unbalanced, they can fall, they can hit their head, okay? Why is it important to get their past medical history when ruling out a neurologic or diagnosing a neurologic disorder?
So if it's baseline or if it's a new onset?
Absolutely, right? Is it baseline for them? Were they born premature? Did that cause that issue because they're not fully developed yet, right? They're not ready to be out. So is that causing their neurologic issues? Did they have a difficult birth? So do they get stuck in the birth canal? Do they have, the nuchal cord that caused some brain damage? Maternal history, again, we touched on that, right? Did mom have an infection? Or was she on some medications that can cause some birth defects? Some psych meds, right, can cause some birth defects. Did they have a fall? Are children prone to falls? In so many ways, right? Not only on their own, but just through sheer lack of watching them, right? Or a misstep in taking care of them. So, maybe the caregivers left them on the couch and they rolled off. Or they had them on the changing table and they turned to grab something and they rolled off. Babies are really quick, right? And they move faster than you think they do. Okay. And then did they have any recent trauma? So did they have, were they out skateboarding or roller skating or on their bike and they didn't have a helmet on, right? Could that lead to a neurologic issue? Absolutely. So what are some common signs and symptoms that you would see in a kiddo with a neurologic disorder? Facial grimaces, fussiness, irritability, what? Their motor functions, so they become uncoordinated, right? So you can see that they've shifted to being coordinated to maybe uncoordinated. Confusion. Irritability. Visual disturbances, they might tell you they've got like halos or blurry vision, right? That nausea, vomiting. Why the nausea, vomiting? That increased ICP, right? Okay. It's putting extra pressure on the brain, and that's where our vomiting center is, right? So if you're putting pressure on that, is that going to cause them to have those symptoms? Absolutely. Right. Good. So what are you looking for when you're inspecting and observing a child that you think has a neurologic disorder? Okay. Checking their cranial nerves. Are they able to follow commands? Are they able to do those things? Vital signs. Their level of consciousness. How alert are they, right? Are they alert and talking to you and responsive, or do they look a little more lethargic? Are they kind of stuporous or rotunded? Or have they completely slipped into a coma, right? And we'll go over those terms in a little bit. You're assessing the head, face, and the neck. What are you looking for? Deformities, swelling, bruising, right? Okay. You talked about cranial nerve function. So are you able to evaluate their sensory and motor pathways, their motor function? Have them move their arms, right? Can they touch their nose, right? It's almost like doing a sobriety test. Can you do these things, right? Absolutely, okay? Because we want to know what's their motor function, what's their reflexes, right? If you like flick your finger at them, should they blink their eye? Should they keep it open? No. So if they do, could there be an issue there with the reflexes? And then signs for ICP, right? So headache, vomiting, lethargy. Kind of all of those same things that you talked about in critical care, right? So we're just kind of reviewing it and just pulling that stuff forward. Okay. Okay. And then we're looking at decorticate and decerebrate posturing. So what do those mean? Okay. What's going on? Why are they in those posturing? The ICP, right? Whatever's going on up here is causing so much pressure that it's putting them into these positions, right? So your decerebrate posturing presents with rigid extension of both arms and legs. This posturing suggests brainstem damage, right? Where decorticate is the cerebral hemispheres, right? So your decorticate is up here, decerebrate is your brainstem, right? So it depends on where the damage is, what position they're going to be in, what posturing they're going to present with, okay? What labs do you want to do when you're suspecting someone has ICP?
Depending on the reason.
It depends on the reason, right?
Infection or it's traumatism.
Yeah, absolutely, right? What's the underlying cause? Is it a trauma cause? Is it a infection cause? Do we not know? So then we're gonna do a combo of the both, right? So if it's a trauma cause, are we really gonna do labs? We might get some, right? But like just kind of basic labs. But what if it's an infectious process that's causing the ICP? Yeah, you're gonna run cultures. Where are we gonna grab those from? Spinal fluid, absolutely, right? We wanna know what's going on there. So we're gonna do an LP, right? We're gonna do a lumbar puncture. And we're looking, is it a viral cause or is it a bacterial cause? Which one's worse? Why? Okay, it's eating sugar and it's proliferating, right? Unless we treat it, it's going to continue to grow and cause a problem and get worse. Viral is self-limiting, right? Usually 7 to 10 days. So we're really just treating the symptoms, right? So if they've got a headache, we're gonna give them some pain medicine. If they're, if they're nauseous, we're gonna give them some Zofran, right? Some sort of antiemetic. But if it's a bacterial cause, we're gonna do all those things, but what else are we gonna add in? Antibiotics, right? We gotta treat that underlying cause, okay? So, we wanna know what their EEG is, right? Why do we wanna know?
Their electrical activity in the brain?
Yeah, what's going on with their electrical currents in there, right? Do they have any? Is the EEG showing us that their brain is still active? Or do they no longer have any electrical activity in the brain, right? Looking at the head and neck, we want to know what's going on with the skull, what's going on with the spine. Do they have a neck injury? Do they have a skull fracture? Right. An ultrasound. Can we do an ultrasound of the head? You can in infants, because guess where you're going to place them? On the fontanelles. Great thing with those fontanelles being open, we can actually do an ultrasound and see what's going on in there, right? It's not the best imaging, right? But if those fontanelles are still open, you can do an ultrasound on
Well,
those,
that's like-
right?
On my daughter's hip, she had the dysplasia, and until that socket like solidified into, or calcified into bone, they did ultrasounds before they could do x-rays.
Yeah, yep, absolutely. We can do a fluoroscopy, so this is gonna be a real-time x-ray that's used to visualize the movement of a fluid within the body, including that cerebrospinal fluid, so they'll put some stuff in there and on imaging it will light up, so we know exactly where it's at. Okay, CT, MRI, PET scan, all of those things are going to give us very detailed views, really helping us to diagnose whatever neurologic issue is going on there, right? So again, if it was trauma, was there, is there brain damage? If they have an anoxic brain injury, have they lost all electrical function? Are they brain dead, right? So things that we're gonna look at when they're in a coma, because we wanna know, is there a chance for recovery or not, right? Does anybody watch The Pit? So,
I love that show.
it's a great show. If you haven't watched The Pit, it's on HBO. It's a very realistic medical show, right? But one of the patients on there was an adolescent patient who was in a coma, and the parents were like refusing to take him off because they thought he was coming back, even though they told them over and over he is brain dead, he has no electrical function, right? So then navigating those issues, right? Okay. What medications are we going to use to treat these neurologic issues?
It depends on the reason.
Depends on the reason, right? Absolutely, right? Figure out that underlying cause, and that's going to determine what medications we use, right? If it's a bacterial thing, so like meningitis, bacterial meningitis, antibiotics, right? With viral meningitis, it's self-limiting, right? About 7 to 10 days. So it's really symptom management, right? And then adding those symptom management things onto the antibiotics for bacterial meningitis. We're still gonna treat those things, but we have to have the antibiotics for that. What if the neurologic issue is causing seizures? Okay, you said phenytoin? Okay. Yeah. Yeah, what did you say?
That's what I said,
Okay.
but I always mispronounce stuff, so.
Yes, phenytoin. Yep. Yeah, so some sort of anticonvulsant, right? Whether it's like Ativan or diazepam or phenytoin, something to control those, so those anticonvulsants. We've got the benzodiazepines as well, to help stop the seizures. And they also help with muscle spasms. So in like cerebral palsy, where they've got muscle spasms and they're just kind of twitching and jerking, so you'll see that they've got some benzodiazepines on board to help with those muscle spasms, right, and kind of calm that muscle activity down a little bit. Okay. Analgesics. You think they're going to be in pain? Yeah, right. Depending on the disorder, right? Okay. Osmotic diuretics will help. Like what? Mannitol, absolutely. Good. And then corticosteroids. That's going to help bring that inflammation down. Okay. Then we've got some other interventions. So we've got our medication interventions, and then we've got other interventions. So one of the things that you might see is a ventricular shunt placement. What disorder do you think that's going to be ideal for? Hydrocephalus, right? So hydrocephalus is what?
Fluid.
Extra fluid on the brain, right? There's an imbalance of the cerebral fluid being produced and absorption, right? So then it just kind of builds up and creates increased intracranial pressure that way. So particularly in the ventricles of the brain, right? So not all over, just within the ventricles. So then as those expand, it puts pressure on the brain, causing that ICP issue. So they're gonna put a ventricular shunt in there. Where's it gonna drain to? Yeah, it drains into their peritoneal cavity, where it is then absorbed there. So what you'll see is that someone who has one, you'll see it kind of implanted, it kind of sticks out a little bit and comes down like the side of their neck, and then goes down, and you'll see it's coiled in their abdomen. So if you were to take an x-ray, you'd see that it's coiled in there. Why would it be coiled in there? Okay, think about it. We'll talk about hydrocephalus in a little bit. We'll talk about more of that, okay? You might see that we've got some PT, OT, ST, right? So physical therapy, occupational therapy, speech therapy. Again, depending on what these disorders are doing to the body, what interventions are we looking at that are going to help them? Okay. They might need a vagal nerve stimulator. Has anyone seen or heard of a vagal nerve stimulator? Want to talk about it?
And just, a whole lot to talk about. Katie's had seizures, they had this thing implanted and seizures basically stopped.
Yeah. So the vagal nerve stimulator is implanted under the skin, usually on the chest, and it's attached to the vagal nerve, and it's activated via a magnet. So when you swipe the magnet over the stimulator, it sends an electrical pulse to the vagus nerve that then is supposed to go to the brain and unscramble the scrambledness that the seizure is causing.
Does that work for SVT too?
Potentially.
They want you to stimulate the vagus nerve,
Yes.
right?
Yeah. I mean, I guess if they were like going into it a lot, but I don't know.
Those are usually just like cardiac defibrillator.
Yeah. It's a little different. Yeah. This one particularly goes to the brain to unscramble or scramble this thing. Okay.
It's just like a pacemaker defibrillator.
Yeah. Ketogenic diet can help, right? Low carb diet that can help control seizures in some children. It doesn't work for everyone, but it is something that they've tried. So the kiddo that I took care of back in Colorado doing home care, he was on a ketogenic diet. He was on very specific stuff to kind of help control overall. Kind of works, not necessarily. He had a lot of other things going on too. So prenatal risk factors for neurologic disorders, we kind of already touched on these a little bit. So prematurity is one, maternal drug and alcohol use, right? Those can lead to what kind of defects? So not so much with the drug and alcohol, that is a lack of folic acid, right? But the maternal drug and alcohol, we're looking at things like fetal alcohol syndrome, low birth weight, right? Because all the vessels are constricting, especially if they're a smoker, right? Perfusion isn't getting there, okay? Maternal infection, we talked about that. Rubella is a huge one that can cause defects in children, okay? Cytomegalovirus, both of those can cross the placenta and into the fetal brain. Ingestion of teratogen, so like lead, mercury, some medications. So those who are pregnant are told they have to follow a specific diet to an extent, right? What not to eat because it contains those things, right? So sushi is one of them, no raw fish, right? I think like soft cheeses are another one, like those sorts of things, okay? And then fetal malnutrition, right? So whatever is causing them to not get enough of the nutrients that are going there, so maybe there's a defect in like the placenta, or maybe the person who's pregnant isn't eating well, right? So if they're not eating well, is the baby gonna be getting all the nutrients they need? No, right? If they're not available, it's not gonna get there.
What do you with those patients so that they have like pick a diet, or they just wanna eat like dirt and stuff?
Right? Yes. Yes, so some will develop pica where, yeah, they just want to chew on dirt. So that's not great, right? That could introduce all of those sorts of things, right? So they gotta have good nutrition. Okay.
Increase the iron.
increased
That's why
iron.
they crave it, because they're deficient in something.
Yes.
Some
Yes, that's
people,
usually
right?
what happens, like their body is craving something, because they're deficient in that. And so but then they get these weird cravings that, like, instead of just taking, you know, a supplement, they go out and they get a handful of dirt and eat it instead, right? Okay, so ICP, what's the basic patho of what's going on in ICP, regardless of the cause?
Too much pressure is building up, and there's nowhere for it to go.
It's not the space for
Exactly.
brain and the
Yes.
glands and the.
Yes, because once the sutures start to fuse, right, there's no place for that brain to expand. So regardless of the cause, what's happening is there's only a limited amount of space, right? So as it swells, it's putting pressure there, and then we start to see all of these signs and symptoms that go along with it, okay? And again, head trauma, birth trauma, hydrocephalus, infections, brain tumors is another one that we didn't talk about yet, right? Brain tumors, as they grow, can put pressure on the brain and cause ICP that way, okay? So, what are your early signs of ICP? Decreased LOC, right? That's one of the first things you're gonna start to see, right? That their level of consciousness starts to change. Okay. Followed by what?
Changes in respiration.
Okay, changes in respiration, changes in their pupils.
They have that nausea or vomiting without nausea.
Okay, vomiting without nausea, or they have nausea as well. Okay. What's gonna go on with their fontanelles if they're open? Bulging fontanelles, right? Absolutely. Okay. So, when a baby cries, their fontanelles bulge, right? But when they're calm, they flatten back out. That is normal, right? When they cry, there's a little bit of increased pressure there, so you'll see that it like bulges and flattens as they're crying, right? But if they have ICP, it is going to bulge and it is going to remain bulging, right? It will not go flat, okay? They might have like sunset eyes, so you know like those dolls that like their eyelids, depending on their position, like open and close. So that's what those like sunset eyes are, right? So they just kind of, their eyes just don't look right, okay? They look like those dolls, okay? And then what are your late signs? Cushing's triad. This is where you're gonna see that posturing, right? Decorticate or dycerebrate posturing, fixed and dilated pupils, so their pupils have just blown, right? So, you know, shining the light in there is not gonna have any sort of reflex. You're not gonna see that. You're gonna have irregular respirations?
Are we gonna have to know between late and early signs because,
No,
okay,
we're not gonna go that deep.
thank you.
The Glasgow Coma Scale, you guys have seen this, right? You went over it in critical care. So, we do have a pediatric one that is adjusted because some of our patients can't talk, right? So how are you gonna get their verbal response? So, so less than 2, when you're assessing their, response to auditory and or verbal stimulus, do they smile and listen and follow you? Are they crying and unconsolable? Do they have an inappropriate persistent cry? So is it like high pitch? There's like a very distinct neuro cry that they have. Has anyone heard the cry of a baby who's withdrawing? It is a very high-pitched, like shrill cry, right? It doesn't sound normal, right? That is that like inconsistent, inappropriate, persistent cry, right? It's just very high-pitched, okay? For our kids older than 2, it's a little bit closer to the adult because they should be talking, right? At least a little bit. But what are what are they saying? Is it incomprehensible? Can you not understand them, or can you understand what they're saying? Okay, using inappropriate words. So maybe, you know, you're asking them to like name objects, and normally they would know what those are, but instead of like if you show them a picture of a dog and they tell you that's a bike, right? That would be inappropriate. Okay. So it changes a little bit based on their age, because again, we can't have them, you know, our kids younger, or our infants, we can't have them touch their nose, right? They're not doing that. But when you're looking at them, are their movements appropriate? Does their cry sound good? You know, are they, if you pick them up and hold them, do they become consolable? Do they calm down? Or are they gonna continue to cry? Okay. So these are the 5 stages of consciousness that we kind of talked about, that I touched on just a little bit ago, right? So fully conscious. They're fully conscious. How do they look? Not like you guys right now. They don't.
Maybe if they're shy, they could be shy.
They could be shy. They
And
could
they
be
could
shy.
be exactly like us.
Right? They could be shy. Okay. But they are alert. They're oriented. They're awake. They're doing the things that are appropriate for their age at that moment. Right? They, you know, they're interacting with their caregivers appropriately. All of those things. Right? Then we see that they have a little bit of confusion. So they're not necessarily going to be able to tell you where they are or what time it is. They might have inappropriate responses. Their memory, their attention is impaired, right? So just off of their baseline a little bit, right? So maybe they were able to tell you those things and now they're not. So does that send up a red flag? Yeah, right? Like a kid who should be and has done those things is no longer able to do those. So now you're like, why? What's going on, right? And then you kind of move down into obtunded. With that confusion, that's also where you're gonna see a little bit of the lethargy, right? So they're a little more tired, but when you stimulate them, they become awake, right? But they're not necessarily appropriate in their responses.
Disoriented to time, are they ever oriented to time? Older kids.
Some of them, because this is just kind of generalized, right? So you're looking at like our school age, who should be able to tell you what time it is, or adolescents should be able to tell you what time, right? Obviously our infants aren't going to be able to tell you where they are, or what time it is. Yeah.
I mean, kindergartner probably not either.
No, because they're just starting to work on time. So probably not, but they should be able to tell you where they're at,
Yeah.
right? And if they tell you, you know, if you ask like, you know, where are you, and they tell you they're at Culver's instead of in the hospital, like that's a problem, right? So it'd be like that
Or
inappropriate
if they
response.
just say, I don't know.
Yeah, that's really cold.
Yeah, if they say they don't know, then ask them other questions that they might know a little bit better, right? So if you started asking them like, who's this in the room with you? And if they tell you that's Uncle Joe, but it's really their mom, right? Then, so you're getting inappropriate responses. So you're just think of the questions that you would have to ask and adjust based on their age, right? And the things that they should know, right? If they have, you know, if they have a stuffed animal that like they've given a name, do they know, like, can they tell you about it, right? Things like that. Okay. So obtunded, they're drowsy. They can be aroused with moderate stimulation. So this is a little bit more beyond the lethargy, where like with lethargy, you go in, you start talking to them, and they do kind of wake up and respond to you. But this is where you might have to like put your hand on their shoulder and like shake them awake a little bit. And as long as you keep them kind of engaged, they should be able to stay awake, but then kind of drift back off a little bit. They're slow, the responses are slow, they're often incomplete, so in the middle of a sentence, they might just kind of drift off and stop. Where then you have to put your hand on the shoulder again and be like, hey, can you finish telling me what you were saying? Okay. Stupor, this is very vigorous or repeated stimulation to elicit response. So like a chest rub or a sternal rub is what's gonna get them awake. and then your responses aren't going to be very much, right? You might only get a little bit, and then they're definitely gonna drift back off again. And then coma, are they really responsive to any stimuli? Yeah, they're just there, okay? No voluntary movements, their reflexes are gonna be absent. Do we need to do something? Yes, medical intervention is absolutely necessary, right? Okay, so often these will go sequentially, right? So you're going to see a progression from fully alert on their way to coma. Should you be doing something before they get to the coma? Yes. Recognize the changes in your patients and call your physician and let them know, right? We should not get to that point if we can intervene early and the appropriate interventions are in place. Okay? Feel pretty good with all of that so far? Most of that was kind of review-ish, right? Just kind of with a little bit of a pediatric spin on it. Okay? All right, when we start looking at seizure disorders, yes, we see a lot of seizure disorders within the pediatric population. However, our curriculum decides that we only need to cover febrile seizures. So that is the only one we are gonna cover, okay? So when you are looking at all of the seizure disorders, the only one you need to take a look at is febrile, okay? But overall, seizures are what?
Bad?
They are bad, okay? They're scary, right?
Yeah.
What causes them?
Overstimulation that affects the brain activity.
Absolutely. Overstimulation that causes the electrical activity to just kind of scramble, right? And sends them into these seizures. With imaging, sometimes we can diagnose like where the seizures are happening. So if it's happening in the same spot in the brain every single time they have a seizure, guess what they can do?
They like, can I cauterize or like that?
Do an ablation, just like they would with the heart, right? So if they know that there's something going on with the electrical pathway in the heart that's causing something to happen, they'll do a cardiac ablation, right? To try to help with that. So they can do that in the brain. They can go in and they can ablate the brain in that area to try to get the seizure disorder to stop, right? So if you no longer have that piece that's sending out those signals that says, hey, it's time to go into a seizure, it's not gonna cause them to go into a seizure, right? But what do you also risk while doing that? Damage, right? So then we could see some other neurologic effects with having, when they go in and because they're destroying a part of the brain, right? So depending on what part of the brain that controls, what are we gonna see as far as the disorder moving forward? Okay. They manifest in various ways and have different causes and treatments. Again, the one we're gonna take a look at is a febrile seizure. So how are you gonna treat this one?
Just keep their fever under control.
Control their fever, right? They're gonna get antipyretics, right? So typically, we're gonna see that these happen as a high fever, somewhere between the age of like 6 months to 5 years. Beyond 5 years, most of the kiddos who are diagnosed with a febrile seizure disorder will have progressed out of them and will not have them anymore, okay? Sometimes these happen without the presence of an actual infection. Something caused a change in their temperature and it set off this like febrile seizure, right? So they could look perfectly fine, have no symptoms of like an upper respiratory infection or any other infectious process, but their body decided to raise their temperature and have this febrile seizure, right? So you're gonna do the vital signs, you're gonna see that they have a fever, you're gonna treat it, right? What else are you going to do with that while also treating the fever?
Watch it if it gets too long.
Watch it if it gets too long, right? Seizure precautions, okay? So these kiddos are definitely gonna have, if they're in the hospital with us, we're gonna implement all of those like seizure pads, right? Making sure that they're nice and safe. We're gonna watch it because if it lasts too long, then we might have to give an anticonvulsant as well, right?
Just out of curiosity, is
anything that's causing their body temperature to go up, absolutely.
It's usually
Yeah.
a rapid shift in temperature.
Yes, yeah, it's something that doesn't happen usually over time. It's something like spikes their temperature and then it like sets it off, right? And so that's why like sometimes it's like in the absence of an infection. It could just be that they were outside and their body got too hot. Yeah. Okay. So really, most of it is just managing that fever, right? If they're having one, how are you going to administer your Tylenol? You're gonna give it per rectum, right? You're gonna put it up there. Okay. It really is not any more extensive than that. Feel pretty good with that. They have a fever, you're gonna treat it, you're gonna keep them safe. Okay. All right, so now we're gonna take a look at some structural defects that cause some neural issues. We're not gonna go over all of these. We're gonna kind of stick to the hydrocephalus and the neural tube defects. We'll briefly touch on like Rye syndrome because that also causes brain swelling. Okay? But these are some other ones that you'll see. So microcephaly. So this is smaller than normal brain size, right? It did not develop, so it is much smaller. It's incomplete development, which then leads to what? What are we gonna see as far as neural function? Delays, absolutely, right? Cognitive function and motor skills. So these kiddos probably will never walk. They're not going to they're not going to speak. You know, they're just pretty much going to be bedbound in there, right?
So they have a shorter life?
They could, absolutely. And sometimes that is like incompatible with life. Sometimes they don't live very long. Yeah. No, they don't live very long. Your Arnold-Chiari malformations, these are where the brain tissue protrudes through the brainstem. My cousin had this. And there is a difference between type 1 and type 2. You don't really need to know the differences really at all, other than you may see this with spina bifida. Oftentimes they go hand in hand. Okay.
Isn't that like, do they live as well? Because isn't that what happens with like ICP? If it gets too bad, it starts going through there and they lose.
Yes, so it is, yeah, so my cousin's still alive. I can't remember which one she had, type 1 or type 2. But the brain tissue that they took out, she now has a lot of issues with weight. So she, growing up, when we were kids, was very fit, very healthy. And with this procedure, it caused her to have significant weight gain and some issues there, right? But she's, other than her weight issues, is very much herself. It didn't really change her like personality or anything like that, but they have to go in and they do have to take out some of that brain tissue. So you risk having some lasting issues. We'll talk in depth about hydrocephalus, craniostenosis. We're not really gonna touch on that a whole lot. That's just the condition where those sutures prematurely close. So then as the child is growing and developing, the brain has nowhere to expand, right? It can't grow because the skull is fused already, right? So they will go in and they'll do like a craniotomy and open those sutures and allow for
Can they
expansion.
open the sutures?
They can, yep, absolutely. And then positional plagiocephaly, where the skull flattens on one side due to pressure from the baby's position in the womb. So if they were like pressed up against one side and they didn't like move in there, it's going to cause a nice flat spot before they even come out, right? Okay. And then afterwards, if they're just left to lay there, they're not picked up, they're not held, they're not doing tummy time, right? then they get that flat back, right? Okay. Other than it just kind of like changing the shape of their head, instead of it being a nice round-ish shape, they just have one spot where it's just like nice and flat. But it's still, like, the brain can grow and develop and doesn't usually cause any lasting effects. And then our neural tube defects, so this is gonna be our spina bifida, like encephaly, where the brain, the skull, and the scalp are all missing, right? They're not present. This is also not compatible with health. And then all of those are a result of a lack of folic acid. Right. Okay. So we'll get into those. The ones that we're really going to cover now, we'll get into them a little bit deeper. So the first one we're going to talk about is hydrocephalus. So what's, again, the patho behind hydrocephalus? Specifically in the ventricles of the brain, right? So this isn't fluid all over, it is excessive fluid in the ventricles of the brain, right? And it is that imbalance of production and absorption. So they're producing too much and it's not getting absorbed back like it should, right? So there should be a nice balance, right? We function without, with a good balance, right? But those with hydrocephalus are not able to absorb it, so we need to put in that shunt, right? So this is what they'll do. They'll put in the ventricular catheter, and you'll see it comes down, it goes behind their ear, and then in front, and then empties into their peritoneal cavity, okay? Where it is then absorbed back into the body there. Okay. So what are some complications that you're gonna see? What's the biggest complication that would happen with someone who has a ventricular shunt? Okay, infection, that is a big one. Not the one I was going for, but that is a big one. Increase in ICP, why? Because the shunt's not working. So if the shunt malfunctions, and now they have that imbalance of CSF, right? So that shunt is pulling off enough that those signs and symptoms of ICP shouldn't be there, right? But if that shunt malfunctions and it's not able to drain that CSF, it's going to build up, and then we're going to start to see those signs and symptoms of ICP that we talked about, right? So definitely things that you want to look for in your patient with one. So if they're, you know, if they were great, they were good, they were alert, fully conscious and talking to you, and now they're kind of confused or obtunded, could there be an issue with their shunt? Absolutely. So definitely something we want to take a look at, right? So making sure that you're closely monitoring for shunt malfunction, for infection, making sure that education for families is really touched on as far as like shunt care, providing emotional support to children and their families, because are they going to be able to do everything that a child of their age should be doing?
As long as it's managed, yeah.
Huh?
As long as it's managed, you should.
Yeah, but are they gonna be, like, what if they like football? Are they gonna be able to play football? Right? So as they grow and develop, how are we going to incorporate their growing developmental status, right? So they might not be able to do everything that children of their age can do, right? They have to be really careful that they are not going to get that, like, knocked or pulled or cause something to happen for some malfunction, right? Right? So if they've got a malfunction, what are you going to see? What? Speak up.
Well, the bulging, whatnot, vomiting.
If it's open, right? Vomiting, nausea, seizures, bulging eyes, elevated vital signs, right? Cushing's triad, right? All of those signs and symptoms that we talked about, right? Things to look for in your kiddo with potential for ICP, right? So decreased responsiveness, and if it's infection, maybe they've got local inflammation along the shunt, right? So if they've got an infection there, you're gonna see that maybe there's like a nice little red track mark, right? That is inflamed along there, okay? All right, pretty good with that? It's pretty straightforward. They put a shunt in, it drains it into the peritoneal cavity. You're gonna look for signs and symptoms of ICP, provide emotional support, right? And watch for infection, okay? So that was one of our structural defects, right? There's something going on structurally there, right? Now we're going to touch on some infectious ones. The ones we're going to take a look at are bacterial meningitis and Rye syndrome, okay? As well as viral. So you're gonna compare and contrast viral versus bacterial, as well as talk about Rye syndrome, which is very rare, right? But it can happen in kiddos. The recommendation is actually less than 19. They should not get what medication? Aspirin, right? Unless they have Kawasaki. See, you guys are ready for your test.
If that's the question, yeah.
Okay, Rye syndrome happens after a viral illness and they were given aspirin for it, right? So we want to not give aspirin during what potentially could be a viral illness because it could lead to not only a swelling in the brain, but it can also end in liver damage as well. So now we're affecting two areas, right? Okay. So, when it comes to the management of neurologic infections, what do we need to do? Okay, antibiotics if it's bacterial, and just symptom management if it's viral, right? Because viral is self-limiting, usually lasting about 7 to 10 days, right? Just like our other viral illnesses, they all usually last about 7 to 10 days, right? And during that time, we're just doing symptom management. If they've got a headache, you're gonna do what? You're gonna treat it, right? You're gonna give them some sort of, either acetaminophen or ibuprofen, right? What else do we need to do besides medication management and symptom management? How can we help those symptoms non-pharmacologically? A quiet environment.
Cool the room.
Cool the room.
Prevention, just exposure.
Okay.
Dim light.
Dim the lights. What else? Okay. Hand hygiene. Wash your hands.
Or you treat like an ICP patient, or you'll treat an ICP patient?
Yeah. How would you treat an ICP patient? Right? Low stimuli environment, right? Dark, no visitors, no phone, no TV, no radio, no like harsh smells, right?
Make sure the parents aren't fussing it them too much, maybe.
Yes, making sure that the parents aren't if they're there, that they're not interacting with their child a whole lot, right? Because we want their brain to rest, okay? So you can put like an eye mask on them so that their eyes don't open. We don't want any sounds, really, so a nice quiet environment, so no TV, so parents are gonna get real bored. Your child's gonna get real bored, right? Because they don't have the TV, they don't have a radio, they don't have like music playing, they don't have like, you would think that aromatherapy would be helpful to kind of keep a nice, calm environment, but what is the brain doing with the aromatherapy? It's processing input, right? Any sort of input or stimuli into the brain is making the brain work, right? So we are going to avoid as much of it as possible to manage those symptoms, right? To give the brain as much rest as possible. Now, is it ever going to be completely quiet? Is the environment going to be ever completely free of smells? No, right? But we're going to try to eliminate exposure as much as we can so the brain isn't having to process a whole lot, right? and then telling them not to think. Does that work? Can you ever just shut off your brain and like nothing is going on? No, because like when I, right, it doesn't ever turn off, because then
Depends on whether
like,
you're a boy or a girl.
I don't know, my brain doesn't shut off. Because when you tell someone to stop thinking, then they're thinking about stopping to think, and it's just like this cycle, right? They have to think about not thinking, and it just cycles out of control. So it never really stops, right? But we can try to mitigate as much of that stimuli coming in as possible, okay?
It's just like their cell phone, nobody taps it.
So, looking at and comparing viral versus bacterial meningitis, right? Some of the signs and symptoms that you're going to see are very similar on both sides of it, right? Your viral meningitis is often referred to as like an aseptic meningitis, less severe, usually self-limiting, 7 to 10 days, right? Whereas bacterial meningitis is severe and it's life-threatening if we don't treat it, right? Because they need those antibiotics. It can lead to brain damage, hearing loss, and death if we don't treat it, right? So, how do you know which is which? How do you know what we're dealing with? We need the cultures. We need an LP, right? Our lumbar puncture is going to be our definitive diagnostic procedure. Is it a bacterial thing or is it viral? So if we do the lumbar puncture, how do we know it's viral? CSF is usually what? It's usually clear. So if there's something growing in it, it's going to look cloudy, right? So that's going to be your bacterial, right? So when they do that lumbar puncture and you're seeing that CSF that comes out and it's nice and clear, you're looking at viral. If it is cloudy, it is bacterial. But they're going to send it to the lab, they're going to process it down, and they're going to tell you for sure if there's if it's a bacterial or viral cause, right? In that CSF, we also have glucose, right? Is it going to be high with viral or normal? Not necessarily high, but are they going to have a normal level with viral? Yes. With bacterial, what's your glucose going to be? It's going to be low because your bacteria is eating the glucose, right? Right? So your glucose in your CSF is feeding that bacteria. So you're going to have a low glucose in that CSF, right? But you're going to have a normal level of glucose in a viral process, okay? You're going to see that yes, they have fever, they've got this stiff neck, right? Because there's inflammation there, so they're going to have those things, right? So we really need to kind of rule out what it could be. So are we going to place them on an antibiotic until we know what it is? Yes. So we're going to grab those cultures, right? And then we're going to give those antibiotics, right? Because we don't want to give them and then grab the cultures, because is that going to throw off our results? Yes, absolutely, right? So we do need that, okay? One of the things that you can test for are these two signs here. The Koenig sign, so you're going to put them flat. You're going to flex their thigh and their knee. So like, pretend I'm laying flat. So their knee and their hip are going to look like this, and then they're going to try to extend. If they have bacterial meningitis, it is going to cause excruciating pain through the hamstrings and into their lower back. Okay. The Brudinsky sign, you're going to have them laying flat, and you're going to have them flex their neck. Okay. When they flex their neck, it should cause involuntary flexion of the hips and the knees. Right. So when they do that, it will pull it up. Okay. So if they're having those things, if it's bacterial, yeah. You won't necessarily see that with viral, but you will see it with the bacterial. Okay. We do have vaccines that prevent against this, right? Which ones? Our meningococcal, our Hib, and our pneumococcal. So those three have all significantly reduced the incidences of kids being admitted with a suspected meningitis. Okay. So, how do you hold a kid for a lumbar puncture?
Like this. Okay, just kidding. I just saw the video. I was gonna put like a little strap to the side.
Oh, for a lying down healthy, picture babies lying on their side, if their pelvis tilted, knees flexed, and some gentle flexion on their spine to give some curve in the lumbar region.
How would you prevent them from wriggling around?
For a sitting up healthy, you want
Holding
to
them
translate
really tight like
position
that.
up by 90 degrees. Various ways you can do that depending on how big your baby is and how big your hands are. You can hook.
I have never seen them do it this way. It is usually them laying on their side. It is just a lot, cause she's gonna add towels and everything to like help support. Have small hands, it's a lot to just kind of hold onto. So putting them on their side and then putting them into that you're gonna really expand their spine when you kind of squish them together, right? Bringing their head to their knees. Okay. Okay. This one is going to show you, is going to walk you through a lumbar puncture. Has anyone seen a lumbar puncture done? A couple of you? Okay. So this is going to walk you through how to do a lumbar puncture, and then we'll take a break. We're going to talk about it first, after. I want you to see how many times this doctor breaks sterile field. And as he's going through, absolutely shout out, he broke sterile field and what he broke when he did it.
Is that how people get prions?
Huh?
Is that how people get prions?
Get what?
Like prions disease?
Through a non-sterile LP, potentially. This is like an adolescent or like young adults, but it's good to see how they do it.
Right.
Has he broken sterile field already?
Yeah.
Yeah, absolutely, 100%.
Again, I think. What's the point of the gloves now?
Yeah, because where were those gloves first?
Outside the sterile field. On the
And on the floor. He dropped them on the floor before putting them on his table. Right? Did you all catch that? Yeah, he dropped those gloves and then put them on the table and then opened his sterile field for his
And
lumbar
now putting
puncture.
them on the bed,
Uh-huh.
just like.
You can't even see what he's doing on those gloves.
Right. I would really love to know how he actually put those on. Where's his sterile field?
Oh, look at that. Oh, Lord.
Break again.
Oh, completely broken.
What field?
These are the people who do surgery, okay?
Uh-huh.
Back to block one.
His,
Poor guy.
and he's got a smile on his face. They probably gave him something to feel really good before the procedure.
The nurse is almost like,
She
geez.
called in ill.
He's broken sterile field so many different times.
She's just pregnant at this point.
She's like, I could do a better job than this guy.
Uh-huh. Yeah.
I'm calling it.
Put me in, coach.
Yes. Did you see at the very beginning how he got his landmark for where he was gonna go?
Like drew it.
Yeah, so he drew a line vertically and then horizontally, but what were his landmarks going vertically?
The person's waist, I think.
The iliac crest, right? So the top of those hip bones, right? And so the top of the hip down to where it intersects the spine, and that's where they do the lumbar puncture, right? It's not very dark, and he kind of washed it off with it.
I know, you already watched it.
Well, if he did it, then it's not a very good surgeon. Well, considering what he did with his gloves, everything he does now is breaking sterile.
Mhm.
Would that give you like a spinal tap for a C-section, the same kind of process? That's great.
Kind of, yeah.
Yeah, but they're usually better at the sterile field.
Mhm.
Oh, I
He is not very good. Not good at all.
Lawsuit.
Was this for like educational purposes or like?
It is for us.
Why? Why?
I just thought it should call
Here's
it.
what you don't do.
Or is this like a family member?
If we were in that situation, could we stop him or?
100%. 100%. Yes. Yeah. Because his sterile field is where his gloves just hit the floor and he didn't clean off the table again before opening his kit, right? And just, yeah, everything he did is not
Hey,
sterile.
doctor, let me go get you another kit.
Yes. Yeah. It's behind him too, right? So that in itself is also breaking the sterile field, right? So positionally, it's not where it should, right? So he,
He's feeling background for his.
this first thing he's gonna do some lidocaine.
He needs to retire.
You said he was gonna tell us
He's
Okay.
not doing
And so you
well.
can see the lidocaine bubble right there,
Yeah.
but he didn't really laugh. He didn't really wait very long for it to do anything. So there's two things that we can do with an LP, or that the physician can do with the LP, and he's gonna show you both. We can check pressure, so we know exactly what the ICP is, or what the pressure is in there, and then we can pull off the CSF to get a sample. Okay.
You shouldn't feel anything for it, it's already in, dude.
So this is the pressure gauge.
Now, I'm gonna ask you for this pressure measurement, can you move your knees down to bed a little bit?
Why did he ask him to move his knees down a little bit?
To increase pressure.
To decrease pressure. Yeah. So when you draw your knees up, you're putting more pressure in that spinal space, right? So we want them in that position initially, so we can get through, or so that the physician can get through to where he needs to do the LP into that spinal space, right? It opens up the vertebrae. But once he's in there, if he has him move his knees down a little bit, it's going to decrease that pressure. The other thing that he's gonna ask him to do is stop engaging his core, and so stop flexing the stomach. So both of those things increase pressure in the spinal space. So having him completely relax and move his knees down a little bit will get a more accurate pressure reading of what he's doing. Okay. And then to get the sample, it just drips into the tube. So they do not hook up a syringe to pull it off like we would a blood draw. They pull off if they are using the pressure thing, they'll do the pressure thing first, they'll take that off, and then they'll open up the valve, and then it will just drip into the specimen collection vial. There's usually 4 that they do.
I think he does
In that situation where the nurse is grabbing the thing, should she not be, or have sterile gloves on? Cause she's crossing the surgical field.
When she was holding the pressure gauge up top.
Cause she's not wearing any gloves, but she's technically over the surgical field.
Yeah.
True, the puncture's already been done, but
Or at least wearing some sort of gloves instead of just having
bare hands.
Yeah.
Sorry,
Yeah.
no, nothing.
What does that fluid look like? Pretty clear. Yeah. If it was bacterial, like you would definitely see a nice cloudy.
Well, it's not infected yet.
It's not infected yet.
It needs time for the bacteria to grow.
Okay, go ahead and take a break, and then we'll come back and we'll talk about the rest of it.
It's up to you. It's up to you. It doesn't matter.